Hello everyone. Today we are going to continue from where we stopped the last time, and that's on the management and the prevention of HIV. I'm just going to emphasize again that um, the initial regimen for the treatment of HIV is just the use of the two nucleoside slash the nucleotide reverse transcriptase inhibitors plus one integrase inhibitor. So we are going to look at those drugs shortly, and we are going to have an overview of the way they work and their side effects. So don't forget, for the heart, you are using two nucleoside or nucleotide reverse transcriptase inhibitor plus one integrase inhibitor. In some situations, you might want to substitute the integrase inhibitor with either a protease inhibitor or a non-nucleoside reverse transcriptase inhibitor. We are going to look at those drugs shortly. And the reason why we are doing that is just to eliminate the risk of viral resistance. So that's why we are combining drugs of different classes. So you don't have cases of HIV virus being resistant to the antiretroviral therapy. So the first class of drugs we are going to look at are the nucleoside slash the nucleotide reverse transcriptase inhibitors. So these are just drugs that look like nucleotide or drugs that looks like nucleosides that have the ability to inhibit reverse transcriptase enzyme. We already know the function of reverse transcriptase. We know what it does. So it's basically part of the pole enzyme of HIV, and what it does is just to convert the RNA, the double-strand RNA of HIV genome into DNA so that that can be incorporated into the genome of the host via the integrase enzyme. So I have a short acronym here to help us remember those medications. This acronym is going to help us remember part of the side effect of these medications too. So the acronym is ADELS. So when I was in med school, I used to have a classmate. Her name is Odedele. So for some of us that are from the Yoruba tribe, so we know what Odedele means. So I used to call her Dels then back in school. So Adels. So ADELZS. So if you can remember this, it will actually help us. So the A there is standing for Abacavir. Abacavir. Most of the times, I won't encourage us to pay attention to the three-letter abbreviation because it gets confusing. Look at the next one now, emtricitabine, FTC. I mean, there's not F is not even in the letter. I mean, in the spelling. So how come? So that we don't get confused, just pay attention more to the name. Ignore the three-letter abbreviation. If you want to learn it, it's fine. But I don't think you are going to need it for your exam. So A for Abacavir, D for the Danosine, E for emtricitabine, E for emtricitabine, L for lamivudine. So lamivudine, that's L. The Z for 2, so Z is standing for 2. The first is the zidovudine, and the second is the zalcitabine. Actually, we might not really pay much attention to zalcitabine. It's not really frequently talked about. We talk about the zidovudine. It's very popular because you use it prophylaxis, particularly in pregnant women. So, as well as in the child that was delivered from a mother that has HIV, you have to give zidovudine. It's compulsory. Then the hairs is stavudine. So going back again, A for abacavir, D for the danosine, E for emtricitabine, L for lamivudine, the Z for zidovudine, and the S for stavudine. So what's the mechanism of action of this medication? Almost all of them, except one, is a nucleoside inhibitor. All of them are nucleoside except one. One is a nucleotide, And what is that one? That is tenofovir. We are already familiar with this medication. It's a very common drug. Tenofovir, tenofovir, tenofovir. It is the only nucleotide that is. It is only. It is the only drug formulation that has a phosphate group. So the other ones, they don't have a phosphate group, because makes um, what separates the nucleoside from the nucleotide is just addition of the phosphate group, right? So that is tenofovir. Tenofovir comes in two different forms. The tenofovir disoproxyl fumarate, that's the TDF, and the TAF, which is the tenofovir alafenamide. So that is very, very important. Alafenamide, that's the one everybody wants. Alafenamide, quite different from the disoproxyl fumarate. So tenofovir disoproxyl fumarate is quite different from alafenamide, because disoproxyl fumarate has a very high risk of causing kidney injury and bone loss. Please, you have to remember that every time, because of the bone issue and the renal complications. So that's the advantage of alafenamide over the disoproxyl fumarate. Very important. So how does this medication work? They work similarly. The only difference is that for tenofovir, you don't need any enzymes, you don't need any kinase to phosphorylate it, because it's already phosphorylated. But for the nucleosides, the one with the S, you have to phosphorylate them to convert them to the nucleotide before they can now act on the reverse transcriptase enzyme. So what do? All of them have the 3' OH group. So that's 3' OH group. All of them, sorry, I said all of them lack the 3' OH group, please. I'm sorry for making that mistake. So what I'm supposed to say is that all those drugs, they lack the 3' OH group. They lack that group. The normal nucleotide or the normal nucleoside that is being added to the growing DNA chain typically have this 3' OH group. So you can cross-link that with a phosphate group to form a phosphodiester bond to keep cross-linking those strands. But by the time you give somebody stavudine or emtricitabine, which lacks this 3' OH group, it gets phosphorylated, converted to a nucleotide, and that nucleotide will be recognized by reverse transcriptase, and reverse transcriptase will want to incorporate it into the growing strand. But you will not be able to continue the linkage of that growing strand, because your emtricitabine or your lamivudine or your stavudine lacks the 3' OH group. So there's no way the phosphodiester bond can be formed. So it causes DNA change, elongation, termination. DNA chain elongation is ceased. It is terminated because you cannot continue to form the phosphodiester bond that is linking each of the nucleotide of the strand. Very, very important to remember that. So that's the way they inhibit the activity of this reverse transcriptase. And another enzyme that I want us to remember is the DNA polymerase gamma. So aside reverse transcriptase enzyme, they also inhibit DNA polymerase gamma. This enzyme is present in so many cells of the body, particularly in the mitochondria. And what does it do? It is involved in the replication and proliferation of the mitochondrial DNA. So that means that if anybody is on the net, that is the nucleoside or the nucleotide reverse transcriptase inhibitor, it is going to inhibit the DNA polymerase gamma, and it's going to affect the activity of the mitochondria because they cannot replicate their DNA no more. And when mitochondrial activity ceases, we cannot carry out oxidative phosphorylation. So there's no way energy can be generated, right? So the body will be forced to divert towards the anaerobic pathway. And the major product of the anaerobic pathway is what? Lactic acidosis. Lactic acidosis. So we cannot go to our exam and not remember this fact. The activity of this drug on DNA polymerase gamma, inhibiting mitochondrial DNA proliferation, leading to failure of mitochondrial activity, bringing about lactic acidosis. At the same time, we have to consider the side effect of the individual drugs. The Danosine is the first one to go. DP, DP. Most of our pictures, we have DP, 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 the Danosine, the Danosine, the Danosine. Danosine is the only D, luckily for us in this class, that we have. The Danosine, DP. Think about the Danosine causing peripheral neuropathy. Think about the Danosine causing pancreatitis. So somebody uses medication and suddenly present with epigastric pain, you can elicit epigastric tenderness on your examination. The pain is radiating to the back. You can think about pancreatitis from the Danosine. Then we have the two last drugs. So if we look at the acronym, we have ZS, right? ZS, zidovudine, stavudine, zidovudine, stavudine. They have a common stuff. And what is the common stuff? They both disrupt fat activity. So they can cause distribution of fat to the liver, causing hepatic steatosis. They can also reduce fat in the normal areas of the body where they are present, like for example in the face, the cheek. So they can cause, facial disruption, cheek atrophy. That is lipoatrophy because they are mobilizing fat from these areas. So they are going to make the cheek very, very kind of prominent because you are going to lose the fat parts that are there from lipoatrophy. So lipoatrophy is quite different from lipodystrophy, which we are going to talk about. So atrophy just means you are losing the fat in that area. It's reducing, making the bones prominent, right? Dystrophy just means you are mobilizing fat from one part to another part. For example, if somebody is having lipodystrophy from HIV medication, it means that we are mobilizing fat from our arms, from our legs, from the buttocks, from the face. It's going to the trunk, it's going to the back, it's going to the abdomen. So the person is going to have an abnormal, presentation. So don't forget, zidovudine, stavudine, fat problem, hepatic steatosis, lipoatrophy. Don't forget. Then the second to the last is zidovudine particularly, not with stavudine now. Zidovudine is not a friend of the bone marrow. Zidovudine is not a friend of the bone marrow. So zidovudine is a bad guy to the bone marrow. In fact, it exerts more of this DNA polymerase gamma inhibitory activity on the bone marrow. So when it inhibits the DNA polymerase gamma activity severely in the bone marrow, it's going to impair DNA replication. And because we know that DNA replication is very essential for proliferation of our blood cells, white blood cells, red blood cells, the platelet, because of that, it's going to cause pancytopenia, essentially bone marrow suppression. And at the same time, it can also cause megaloblastic anemia because we know that once you cannot form a mature cell, once you cannot form the DNA, to make the cell mature, it's going to appear large, megaloblastic, immature. So that's why, folate deficiency, vitamin B12 deficiency are very integral to forming the DNA component, cause megaloblastic anemia. So zidovudine is doing that by inhibiting the activity of the DNA polymerase gamma severely and at the same time disrupting the folate metabolic pathway. So don't forget, bone marrow suppression, megaloblastic anemia from zidovudine. Zidovudine and stavudine, both of them are not friends to the fat. So they cause lipoatrophy, they cause hepatic steatosis. We talked about the danosine, DP, peripheral neuropathy, pancreatitis. So the last one is abacavir. We are very familiar with this. People that have the HLA combination 57, HLA B57, they are highly predisposed to abacavir hypersensitivity. So you might be very careful in foreign countries where they have the ability to have the sequencing of these HLA phenotypes or genotypes, rather they can actually know, what combination is present and what medication to avoid. So if you discover that somebody have this, you might be careful to give them a Bacavir because it might cause a Bacavir hypersensitivity, which will present as rash, fever, abdominal pain, diarrhea, vomiting, and the like. So once you see rash, think about an hypersensitivity, allergic, fever, rash, abdominal pain, diarrhea, wheezing, Abacavir hypersensitivity. Very important. Then moving on to the next one, we have the non-nucleoside or the nucleotide reverse transcriptase inhibitors. So these ones are not the nucleotide or the nucleoside now, but the non. So these ones, they don't require the phosphorylation like the first one, and the acronym for them is TREND. So I have the acronym here, TREND, to help us. The first one is what? A what? DELS, right? A DELS. So don't forget A DELS. Here it is TREND. So just ignore the T and think about the RAND. Think about the RAND. The R for the ripivirine, the E for the efavirenz, very common. The N for the nevirapine, the D for the delavirdine. The delavirdine. So before we proceed to their mechanism of action, it is important for us to remember that don't ever use in pregnancy. Don't ever use in pregnancy. Don't ever. The first D, the first E in pregnancy. So you want to be very careful of prescription of delavirdine or efavirenz in a pregnant woman because they are both teratogenic. You don't use them in someone that is pregnant. The only good side to use of efavirenz is that you can use it with combination, you know, you can use it in combination with anti-tuberculosis medication without any interference. That's a good part of efavirenz, but efavirenz has a very bad, you know, side effect profile. Like, so they don't require phosphorylation to become active, just like the just like the nucleotide part of the NRT, which is tenofovir. It doesn't require phosphorylation. So, and what it does is just to bind to an allosteric site on reverse transcriptase. You know, it doesn't need reverse transcriptase to be incorporating it into the chain so that it can cause chain termination. No. What it does is just to bind to that reverse transcriptase itself and alter the shape of the reverse transcriptase, altering its conformational shape and the conformational configuration, and it inhibits the action of, you know, reverse transcript in a non-competitive manner, as opposed to the previous ones, the NRT that does their own through a competitive inhibitory pattern. But this one, they bind to an allosteric site, so definitely it's going to be non-competitive. Yeah, it's going to be non-competitive. So what is the side effect? Generally, they are not friendly to the liver. They are not friendly to the skin. The non-nucleotide and the non-nucleotide are not friendly to the liver. They are not friendly to the skin. So they cause skin rash. Think about Steven Johnson syndrome. They cause hepatotoxicity. Hepatotoxicity, skin rash. Just like the NRTs that we have mentioned, the side effect that is common to all of them is that, you know, they what's it called now, inhibit the DNA polymerase gamma, which causes mitochondrial toxicity, causing lactic acidosis, right? So they can also elevate creatinine kinase, but it's not very important. So, that's the side effect that is common to them. Here, these ones generally they are not friendly to the liver, they are not friendly to the skin, so they can cause rash, Steven Johnson syndrome, they can cause hepatotoxicity. Now, we've talked about the ones that are specific, efavirenz and delavirdine. That's it. Don't ever, efavirenz, delavirdine use in pregnancy, right? The ones that are specific to CNS, that is efavirenz and repivirine. We might know repivirine is fine. If you want to learn it, it's good. But the one that you must not ever forget with respect to CNS toxicity is efavirenz. Efavirenz will make the patient present with vivid dreams. They cause mood problems. They become depressed, become anxious for no reason, become confused, can have dreams, serious mood issues. Once you see that, the confusion, the anxiety, the depression, think about the vivid dreams. They like putting these vivid dreams there. Efavirenz is drug at work. Efavirenz. CNS problem, efavirenz. Teratogenicity, efavirenz. Then the integrase strand transfer inhibitors. So it's basically just the drugs that are inhibiting the integrase. So just think about the gravules. Those are the integrase. the gravies. So big tip gravule, dilute gravule, raster gravule. You don't need to learn everything. I just know one or two. Dilute gravule is easy to remember. Raster gravule, just know once you see the gravule, it's the integrase inhibitor they are talking about. And what do they do? Very straightforward. What they just do is just to inhibit the integration of the DNA or the viral DNA into the host DNA, that is the DNA of maybe the T cells or the macrophages. That's what they do. Just inhibit that integration. So, we remember that as part of heart, we have to combine it with two, nucleotide or nucleoside reverse transcriptase inhibitor to form the heart. That's what you do. That's the way you use your integrase. You typically use them as the combination therapy. So what side effect do I want us to know? The fact that it just cause weight gain. Majorly, that's their stuff. They cause weight gain. They cause weight gain. So they are generally well tolerated, so that means they can cause a long-term viral suppression. So that makes sense. So that's why it's one of the most preferred combination medication. So weight gain is one of their major side effects. Elevation of creatinine kinase level is another side effect. They can cause sleep issues, dizziness, another side effect. Yeah. So um so yeah, so then the protease inhibitors, right? Protease inhibitors, they are another class of drugs. Just remember the Navi, the Navi, the Navi, the Navi. Um, Atazanavir, Darunavir, Indianavir, Lopinavir, Ritonavir, Saquinavir, right? So, the common ones that we typically see include Ritonavir and Indenavir. So we might have heard about Indenavir maybe in the renal section when we were talking about stones. It's possible. Ritonavir is also a drug that we are very, very familiar with. So what did they do? The protease inhibitors are just there to inhibit the protease enzymes. And basically, what does the protease enzyme do? The easy way to just picture the function of this protease enzyme is just to look at the progression of the DNA replication. Just imagine you have the virus in the RNA form getting converted to the DNA form. How? Through the activity of reverse transcriptase, right? It's been converted from RNA to DNA. Then what happens to the DNA? The DNA needs to be integrated into the DNA of the host, right? And you employ the activity of the integrase. So what happens to that DNA when it's replicated? You produce multiple copy of DNA to form new variants, right? And the DNA is going to be converted to RNA. The RNA is going to be converted to protein. Now you need to split these proteins into tiny bits so that you can assemble them to form new variants. So what is going to help in the splitting of this long polypeptide chain of protein into tiny bits to form mature individual viral particle is the protease enzyme. So that means that if anybody is on protease inhibitor, it means that that person is not going to be able to split the polypeptide, change into small protein. The person will not be able to split out reverse transcriptase enzyme from the protein. The person is not going to be able to split out integrase enzyme. It's not going to be able to split out polymerase enzyme. It's not going to be able to split out each of those functional protein that is required by the cell, by that virus to survive. So they will never mature and they will be rendered non-infectious. So that's the way the protease inhibitor works. And what do I want us to remember with respect to side effect? Just remember that the protease inhibitor cause problem with fat, just like stavudine, just like zidovudine, they cause problem with fat. And what do? They cause hyperlipidemia. Because hyperlipidemia, when there's too much fat, what happens? Insulin resistance setting, right? When insulin resistance sets in, what happens? Hyperglycemia. So it is not uncommon for people that are on protease inhibitor to develop hyperglycemia, to develop hyperlipidemia, to develop insulin resistance. And they are the ones that also cause lipid, dystrophy, like lipodystrophy. So they kind of rearrange the distribution of fat. So they move fat from the extremities, from the head and neck, they move it to the back and the abdomen. giving that kind of buffalo hump distribution, kind of just an example. So, the fat can also deposit in the liver and they can cause hepatotoxicity. That's just, a way for us to remember that it can be hepatotoxic. And what is some particular side effect of each of those individual drugs? For example, Indianavi stone, Indian stones. That's one thing about Indianavi. They can cause crystal-induced nephropathy and nephrolithiasis. So crystalline, they can precipitate and form crystals that can occlude the lumen of the tubules, just like a cycloview. So that's why somebody's on a cycloview, you have to rehydrate them, give them a lot of fluid, wash out those crystals. That's one way you can prevent crystal-induced nephropathy. Give a lot of fluids. Nephrolithiasis, they can cause stones. Then, one thing about the protease inhibitors is that most of them require boosting. We don't typically use these protease inhibitors alone. We have to give, because they are rapidly metabolized by the cytochrome P450 system. So we have to give some boosting agent that can suppress the activity of those cytochrome P450, and they can make this drug persist a lot in circulation and act accordingly for a long time. So what do? We have two major boosting agents, and they are the last two drugs we are seeing, ritonavir and saquinavir. Both of them, they inhibit the cytochrome P450 system. So by the time you combine them with any of these drugs, so you can combine ritonavir with darunavir, you can combine saquinavir with indianavir. So the ritonavir or the saquinavir is going to inhibit cytochrome P450 and is going to, make the combined drug to persist more in circulation and act for a long time. So we call them boosting agents. There's another drug that is also a boosting agent that we're going to talk about shortly, and that's called Bizistat. So yeah, so that's that. So now you want to be careful, combining rifampin with protease inhibitors, because rifampin is a cytochrome P450 inducer. So by the time it induces cytochrome P450, they will rapidly metabolize these protease inhibitors and they are mobbed out of the circulation. So you need to be increasing the dose of the protease inhibitors, which will not help us. So instead of using rifampin, when you are treating TB, use rifampicin. That's the good part. So once you see rifampicin and rifampin in the option, you want to look at it closely to assess for any possible drug-drug interaction. If you perceive any impending drug-drug interaction, you have to choose rifampicin as a preferred drug compared to rifampin, because rifampin will stimulate the cytochrome P450 and is going to affect the drug you are combining it with. So, and before I move, I forgot to mention that the non-nucleoside and the non-nucleotide, they don't work against HIV too. They don't work against HIV type 2. That's one of their problems. So, the entry inhibitors. So, we have two drugs, the Maraviroc and the enfuviritide. So, enfuviritide. So, from the word fu, fusion. And what is the major protein involved in fusion? Just like we have mentioned before, the glycoprotein 41. The GP41 is a fusion protein. So enfuviritide is going to inhibit that protein, and it will not allow for adequate fusion. That is fusion of the viral envelope of the HIV with the cell membrane of the host cells. So fusion is the final stage. When fusion doesn't occur, cell entry doesn't occur. Maraviroc prevents docking. So docking is just like, attachment of the receptors. So this receptor docks on another receptor. But for them to now, move into one another, you need to fuse them together. So docking is just the initial attachment. Fusion is a final stage, right? So docking involves the activity of GP120. So GP120 is going to interact with the CD4 receptor. Then from there, interact with the co-receptors, which is CCR5 on the macrophages and the T cells, as well as XCR4 majorly on the T cells. So that is why we have to do tropism for the HIV to know what kind of preference the HIV virus has. Some of them have preference for majorly CCR5 receptors, while some of them have tropism for majorly CXCR4, receptor. So before you can give Maraviroc, you have to establish the fact that HIV is tropic for CCR5 receptor. That means it preferentially binds more to your CCR5 receptor to gain entry, right? So you have to do that profiling, that assay, before you can now see if your Maraviroc is best for that patient or not. Because Maraviroc selectively prevent the binding of GP120 to CCR5. So it's more like a CCR5 inhibitor. That's what Maraviroc does. So what's the side effect of this drug? Both of them, they cause skin and GI symptoms. We don't need to waste more time there. We have talked about the boosting agent. I've mentioned this a little bit. I've talked about saquinavir and ritonavir to be the major CYP3A inhibitor. We also have the cobicistat. So all of them, you can use it with other protease inhibitors, or you can combine with a specific integrase inhibitor, and that's envitigraphyl. So you can combine envitigraphyl and other protease inhibitors with ritonavir, saquinavir, or cobicistat, to prolong the duration of the action. That is a boosting mechanism. So it's nothing much there. So cobicistat side effect is just to increase serum creatinine without elevating GFR. It doesn't reduce GFR rather. So cobicistat will not reduce GFR, and it will still elevate, serum creatinine. So that's just about cobicistat. It's not very common. I've thought about where we need to pay more attention. Pay more attention to the specific protease inhibitors that have boosting activity. Pay more attention to the individual side effect of those drugs, and not cobicistat now. No, in Danaville, the side effect of efavirenz, the danosine, those are the common ones that they can ask. It's good to also know cobicistat can elevate serum creatinine. It's good, but it's not commonly mentioned. So what is the phenomenon of immune reconstitution inflammatory syndrome? So this just in summary, it's just like reconstitution of the immune cells, because what HIV does is just reduce the number of the CD4 count, right? So the immune cells become very weak. So if we place an individual on heart and we have a sudden gradual elevation of the CD4 cells, that can provoke a rapid, strong immune response, inflammatory response, which can awaken some underlying opportunistic infections or even bring about new conditions. Most of the time they are infections. Sometimes it can be autoimmune disease like rheumatoid arthritis flare of SLE, flare of sarcoidosis. But most of the time we talk about immune reconstitution inflammatory syndrome with respect to infections. And I want us to pay attention to three major infections. Number one that we have here is Cryptococcus. We will see Cryptococcus more in questions with respect to the immune reconstitution inflammatory syndrome, but I want us to also remember that it might also affect tuberculous meningitis and CMV retinitis. So a patient with CMV retinitis, cryptococcus infection, tuberculous meningitis, you want to be careful about immune reconstitution inflammatory syndrome. That is, once you know that those individuals have this disease in them, you don't want to start heart immediately. You want to treat that infection first before you now commence your heart. But if you are going to give that individual heart first before treating the infection, you have to notify the infectious disease authority of that state. Very, very important. Very, very important, because once you give your ARTs and the immune systems, the immune system becomes built up and, stronger. Your CD4 count elevates. It can trigger a massive inflammatory response that can cause a flare of the opportunistic infection that are underlying, which might be very difficult to control. So most of the time, you just give them steroids. It might not warrant discontinuation of the heart, but sometimes when it's very severe and life-threatening, you might discontinue the heart and you give steroids. So watch out for cryptococcus, watch out for CMV retinitis, watch out for tuberculous meningitis. So in these three conditions, you treat them first before you start your HIV medication, which is the heart. Very, very important. Don't forget that. So what are the prophylaxis for opportunistic infection? So these are just the guidelines, basically. We just have to remember the MOSIS. Very, very important. The MOSIS of the opportunistic infections. So because opportunistic infections are very common in people with very low counts, particularly less than let's say 500. It gets scary when it starts getting less than 200. So before some of those infections even start developing, you want to give prophylaxis against them sometimes, so that you can arrest them from developing. So remember the MOSIS are the coccidioidomycosis, the toxoplasmosis, and histoplasmosis. Then the last two is the avium and the PCP. Everybody knows PCP. Everybody knows the avium. So um, starting from the highest, when the CD4 count is is getting low, like less than 250, think about coccidioidomycosis. But before I move further, to simplify it, the only two, um, or let me say three opportunistic infection that I know that you are just going to base your judgment of giving the prophylaxis solely by looking at the CD4 count is PCP, Toxo, and Mycobacterium avium. PCP, sorry, I said Toxo. PCP, histoplasmosis. PCP, histoplasmosis, and Mycobacterium avium. So PCP, histoplasmosis, Mycobacterium avium. So in these three conditions, you have to, once you see that, okay, the person has gone below their required CD4 count, you can start the prophylaxis immediately. But exception is for coccidioidomycosis and toxoplasmosis. You have to confirm by serology. So obtain serology for toxo. If it is positive, if the IgG is positive, give your prophylaxis. For coccidioidomycosis, the same thing. Obtain your IgG or your IgM. If it's positive, give your fluconazole, right? Give your fluconazole. So then, uh, so for Mycobacterium avium, if the individual is not on heart, give azithromycin. Give azithromycin. If the patient is on heart, don't bother with your azithromycin. So that's the new guideline. So when the individual is having count less than 250, think about coccidioidomycosis. Don't forget, do your serology, IgM, IgG. If it's positive, give your fluconazole. If it's less than 200, just consider PCP immediately and give your Septrin. If it's less than 150, think about histoplasmosis. Give your itraconazole prophylaxis. If it's less than 100, Toxo. Toxo is less than 100, right? Do IgG. Is it positive? Then give your um, Septrin for your prophylaxis. So it's different from the treatment drug, which is sulfadiazine pyrimethamine. Then for Mycobacterium avium, it's less than 50. So you give them azithromycin if they are not at. Please don't ever fall victim and pick CMV or and varicella or anything. These are the opportunistic infections that you give and prophylaxis against in HIV. So live vaccine are typically contraindicated in people with CD4 count less than 200. Once an individual has CD4 count less than 200, that is like severe immunosuppression. Don't even consider live attenuation vaccines like the MMR, like the varicella, like um the I think those are the common ones that we have here. The other ones that might not be relevant to HIV. So MMR, the Zostar, the varicella, they are the common live vaccines that you might want to give someone with HIV, but don't give them once it is less than 200. But if it's higher than 200, you might consider it depending on the patient, health needs and the age. So, that's how you can use your discretion to give those. But most of the time, the question STEM will want to appreciate if you understand this algorithm. They will not typically give you count more than 200. Most of the time, they want to see if you actually know, because they want to, you know, um, test if you can avoid putting patient at risk. So they might want to assess if you know that you are not supposed to give live attenuated when the count is less than 200. So pay attention to that. So other standard vaccine that you must give them, regarding of their CD4 count, is what? Pneumococcal, against meningitis, meningococcal infection, influenza. Before we move further, by the time you are talking about your pneumococcal, you're talking about meningococcal, you have to chip in influenza vaccine there. The inactivated influenza vaccine. So that's the one you inject, and not the intranasal one. The intranasal one is active, live. So COVID-19, which is now rampant now, so you have to give COVID-19 vaccine and hepatitis A and B. Of course, because people that have that develop HIV kind of might have a high risk factors for the STI. So you have to give anti vaccine against hepatitis A and B. So we should not forget that. Don't forget your hemolysis, leukocytoidomycosis when it's less than 250, histoplasmosis when it's less than 150, toxoplasmosis when it's less than 100. You test for your toxo IgG, you test for your coccidioidomycosis IgM IgG before you give their respective treatment. You don't need to test for avium. Once it's less than 50 and the person is on heart, give your azithromycin. You don't need to test for PCP. Once it's less than 200, give the patient your Septrin. You don't need to test for histoplasmosis. Once it's less than 150, give your itraconazole. So the pre-exposure prophylaxis is just talking about um, some certain retroviral medication that I give to an individual that is HIV negative, but the person is engaging in a high risk behavior that might expose that person to HIV. That is what your pre-exposure prophylaxis is talking about. So you just have to consider four major routes: three sexual, one drug related. Three sexual, one drug. So anybody that is, for example, for the drug related, anybody that is an intravenous drug user, that is abusing intravenous drugs intravenously, choking needle every now and then, person has a high risk of developing HIV. So the person might need a PEP, right, before engaging in such behavior to protect him or herself. Anybody that's having sex with male, anybody that is a sex worker, or anybody that is a partner of HIV positive person. So these are the three sexual parts: male having sex with male, sex worker, or partner of HIV infected person. Three sexual, one drug. You have to give your PEP. So as you are about to do such activity, you use your PEP, right? You want to go for sex work, they use their PEP. Want to have sex with male, male having sex, they use their PEP. So most of the time, if it's a one-off process, for example, they just want to have sex with um, male want to have sex with another male now, so they can use their PEP and they can continue the PEP for 28 days and they stop. But if it is a situation when they cannot stop the activity, they continue engaging in sex work, they continue having MS, male having sex with male, they continue using their drug intravenously, they continue having sex with their HIV positive partner, they have to continue that PEP indefinitely. So they basically use PEP before the high risk habit, and even some days like 20 days afterwards. That's where the PEP was. And what drug do you use? You use tenofovir M2-citabine. Tenofovir M2-citabine. So basically, you are just combining non two nucleoside or nucleotide reverse transcription inhibitor. That's just all. Your tenofovir there is your that is your tenofovir there is your nucleotide reverse transcriptase inhibitor, while your M3-cytabine is a nucleoside reverse transcriptase inhibitor. So that is just the only two. You are not adding integrase. Please don't go and pick triple regimen for PEP. So you are just using your tenofovir and M3-cytabine. You take it along as long as the indication is present. But if it's just a one-time stuff, you just use it for 20 days and you stop, right? It's very, very important, very useful in protecting HIV infection from people that engage in sexual activity, as well as 99% chance of reducing, the risk. Why people that are engaging in IV drug use, 74% effective in them. It's not very important for us to remember the percentage. Yeah, nobody's going to ask you what's the percentage, but it kind of protects people that engage in sexual activity more than the IV drug user. That's just what they are trying to drive home here. Don't forget what we have said about the tenofovir. There's a proxy fumarate and that of the alafenamide. Yeah, so we said if you are using alafenamide has less chance of causing bone problems and kidney problems, right? Compared to compared to um, there's a proxy that has a very high chance of causing the bone and the kidney. Alafenamide has a reduced chance. So if they give you both option, they ask you for the side effect, you know what to pick, you know what to choose. So for the post-exposure prophylaxis means somebody did not use PEP and suddenly the person got exposed to fluid or to, person had sex with somebody that has HIV. Just think about three things: sex, needle, and what? Fluid exposure, skin, mucous membrane exposure. So those three things. Forget about what is on the screen because it might be confusing. So you are just going to look at three indications: sexual contact with an high risk person, or even somebody that is confirmed to HIV positive, exposure to needle, exposure of body fluid to skin and mucous membrane that is open. Those are three things we need. So high risk sexual contact means somebody is engaging in condomless sex in an individual with high prevalence of HIV, or like the person who had sex with a sex worker, or the person had sex with an individual with a known carrier of HIV. Definitely that person deserves to use a PEP because all these individuals have a very high risk of having HIV, except the person that is already confirmed. The sex worker, the male sex versus male sex, they have a very high risk of having HIV. So anybody that engage in sexual activity with these two categories, the males versus male or the sex worker, particularly male versus male which are living in areas where there is high HIV prevalence, use your PEP. Use your post-exposure prophylaxis, not pre-exposure, but post-exposure. For the NICU stage, so somebody just sharing needle with an intravenous drug abuser, you are sharing needle with that person, or the person is an health worker that suddenly gets pricked, or that's all about needle. Then for the body fluid, for the mucus and skin exposure, you just have exposure of blood, exposure of breast milk, to the mucosa, like for example, breast milk entering the mouth, you know, semen entering the vaginal mucosa, right? Vaginal, fluid getting into the orifice, any of the orifice, maybe the mouth, open wound, anything, or the person had a bite from HIV positive person, or the person had a blood splash entering the eyes, the nose, the mouth, any of these entering through any of the orifice, the mucosa of the body, the non-intact skin, the person also needs to get a post-exposure prophylaxis. So that's the very simple way to look at it. You don't need to cram anything. Just think about sex, think about the needle, think about the skin and the mucous membrane. That is all. So what do you do? So as against the pre-exposure that we are just using tenofovir and emtricitabine. Here, we are going to add integrase inhibitor to it. So we must give them the antiretroviral therapy to reduce the likelihood of infection. Yeah. So we give your tenofovir, your emtricitabine plus the integrase inhibitor for 28 days. But before you do that, you are going to do a HIV testing through the combination technique. Don't forget the combination technique. P24 antigen with your HIV-1 and 2 antibody test, right? We should not forget that. Don't forget that. So you do it at that moment. You do it after 6 weeks after commencing the medication. You do it 3 months after the exposure. So that moment where the incident happened, 6 weeks afterwards, 3 months afterwards. That's what you do for post-exposure prophylaxis. So it's also very, very important for us to remember the prevention of perinatal transmission. Very, very important stuff. So pregnant women with HIV should undergo perinatal testing. It is a standard in the US. It is a standard, but it's usually through the opt-out approach because you can make it optional. If you want it, you do it. If you don't want it, you don't do it. So you don't force them. So, but all HIV positive pregnant women must be on HEART, regardless of their CD4 count, regardless of their status. They must be on HEART that is tailored to their need, to their profile, rather. So, if any pregnant woman is on any effective HEART, the physician should continue that regimen to prevent perinatal transmission. Very, very important. So, if a patient is not on any prior regimen, you have to comment, you know, an appropriate art, to reduce the viral load and reduce the chance of transmitting to the child. You don't even need to start doing genotyping and seeing which drug is resistant to just start the common one. Pick two of those NRTs and combine it and integrate inhibitor and work with that while you now start doing your genotyping data so that you can switch. So what is it? Basically the algorithm? You just want to quantify the viral load of the mother. That is what is going to define what you are going to do. So at delivery, you want to look at what is the viral load of the mother. That's what is going to determine what you are going to do. So if the viral load of the mother is more than 1,000, definitely you have to do a cesarean section at the time of delivery. Once it's more than 1,000, you do a cesarean delivery and you give the mother intrapartum IV zidovudine. Very, very important so that you can limit, the quantity of the RNA, the virus, limiting its transfer to the baby. But the fixed point I must always mention is that regardless of the mother's count, regardless of the mother, when the mother is HIV positive, that baby must take zidovudine. That one is it is sure banker. The baby will take zidovudine. So at the time of delivery, the viral load of the mother is 1,000 plus. You need a cesarean delivery immediately because there's a very high chance of spreading to the child during birth, and you have to give intrapartum zidovudine. But if it's less than 100 copies, so you want to do a vaginal delivery, you don't need to give intrapartum zidovudine. That's just it. So if some can ask me now that, okay, Valley, what if it's in between, like 900? So if it's in between, you are still going to do vaginal delivery. But you might now use your discretion to now give intrapartum zidovudine. That's just the only stuff that is there. But once it's greater than 1K CS straight, so excuse me. So the newborn therapy, if you have to use the maternal RNA to decide what you are going to do or how you are going to go about it. So if the RNA in the pregnant woman at the time of delivery is less than 50, so you just give the baby zidovudine for 4 weeks only. That is all. 4 weeks. But once the RNA load is more than 50 copies, you have to give 2 or 3 regimen, and the regimen is New Zealand, NZL. Your zidovudine is always there, plus nevirapine, plus or minus lamivudine. So you can decide to use the 3, or you can decide to use just 2, which is zidovudine plus nevirapine. So don't forget, as a key fact, we have said it here, the pre-exposure prophylaxis is very important in 4 situations. 3, sex, 1, needle. Needle, IV drug abuser. So people that want to engage in IV drug, you know, dealings, people that, for the sex one, people that are male having sex with male, sex worker, person, somebody having sex with HIV infected person, right? Those ones are high risk conditions, and you have to give your PEP before and afterwards. If somebody has infectious monocle-like syndrome, and the person is having a very high risk sexual activity, you have to consider acute HIV syndrome, and you have to give your HIV screening, right? Very, very important. Very, very important. So, lifelong antiviral therapy should be prescribed to all HIV patients. You don't say, because my count is not less than 20 micro cells per microliter, I'm kind of okay. It's negligible. I can't detect it. So let me just stop taking medication. That's bad. You continue your medication lifelong. So moving on to CMV, what I'm just going to mention is that CMV is one of those salient infection that it has that many people don't really pay attention to. And it's very important to know in our exam because 70% of adults in the US actually get infected with CMV. So this is of epidemiologically important. So if 70% of adults in the US can be infected with CMV, then we must know everything about CMV. But why they are kind of silent about it is that majority of individuals with CMV are asymptomatic. People can have it, yes, a lot of people can have it, but most of them will be asymptomatic. So it will only come out when there's a form of immunosuppression. Particularly if the person is undergoing transplants, organ transplants, or the person is maybe has some immunodeficiencies from like maybe HIV, cancer, or that. But most of the time, CMV is related to organ transplantation. Why? Because during organ transplantation, there's immunosuppression already from the steroids, from the immunosuppressor to prevent the organ rejection. And secondly, um, uh, from the fact that the organ can also contain CMV. So CMV can be transmitted through different routes. It can be transmitted through organ transplantation, it can be transmitted through blood contact, it can be moved through sharing of saliva, breast milk, respiratory droplets, so many routes for CMV. Just think about everything. Nothing is not possible with respect to CMV. You can move it through any route, almost any route. So we have talked about the risk factor. Somebody that is undergoing transplant, tissue transplant, bone marrow transplant, particularly within the first 100 days. That's when they are most susceptible. Someone that has a background immunosuppression from HIV, less than 50 counts. The viral load more than 10,000. Just think about HIV, think about tissue, bone marrow transplant. Those are the two common cause of CMV. Think about transplant, think about HIV, particularly when the CD4 count less than 50. So, what are those things that they can ask us? The way they will paint the scenario is just to paint the scenario of someone that has Epstein-Barr infectious mononucleosis, basically. So the person is going to be having sore throat, is going to be having fever, going to be having fatigue. The person might be a young chap, maybe 15 years, and the person is having hepatosplenomegaly, the person is having sore throat, exudative tonsillar, lesions, cervical lymphadenopathy, sometimes macropapillary rash. You are thinking, oh, could this be infectious mononucleosis? They did the heterophile antibody test, is negative. They did the EBV specific antibody test, it is negative. So think about CMV. This is step one stuff. Everybody knows it. Very important. We should not forget it. So we should also remember the creep for CMV, the CREEP. So the C colitis. So that's talking about colitis. We don't have the colitis here, but it's important we remember colitis with respect to CMV. It's already here. They said GI and hepatopillary involvement. So people with CMV can have GI and hepatobiliary. Okay, let me start from the first so that we can follow through. So the first is CMV retinitis. CMV retinitis. So CMV can cause some retinal lesions, right? It can cause some retinal lesions that can eventually cause retinal detachment. How does it appear on fundoscopy? Pizza pie appearance. So what does it mean? We are going to see an area of the retina that looks like a pie. So we have fluffy cottonwood spots, opacities. They will be described as fluffy opacities, that gives this cottonwood spot pattern with perivascular hemorrhage. Once you see that, opacities with perivascular hemorrhage, think about CMV retinitis. Somebody that is having a background immunosuppression, somebody that has undergone transplant, think about CMV retinitis. Now, how do they present? Because of the fact that it can cause retinal detachment. So we are going to see floaters, visual field changes. So they can complain of seeing, abnormal lines, floats, like, haziness in their visual field. So I have what it looks like. So this is it. This is like the slice of the pizza. You can see the cottonwood spot here. You can see the area of the bleeding. So the perivascular hemorrhage with the cottonwood spot, the opacity. So just like here, you can see this section looking like a pizza slice, having this V patterning. So that is that. Then GI and hepatobiliary involvement. This GI involvement is very common. Colitis, particularly, can cause colon inflammation. So what you just need to look out for is bloody diarrhea. So you see somebody that's having background immunosuppression, transplantation, history, and the person not having bloody diarrhea. Think about CMV colitis. It's a very straightforward differential. Just think about CMV colitis straight up. Bloody diarrhea, abdominal pain. Someone that's having background immunosuppression or having history of transplantation. Think about CMV colitis. They can also affect the liver and the biliary tree because they can cause cholangitis, right? So it's very common with people with AIDS because they can have this cholangitis from CMV, from some of those infections like microsporidia and cryptosporidium. So cryptosporidium, microsporidium, CMV, they can cause AIDS, cholangiopathy, which is characterized by abdominal pain, they can have jaundice, they can have nausea, vomiting, and right upper quadrant abdominal pain majorly. So CMV esophagitis can cause esophageal lesion, distal esophageal lesions, right? And we typically see, by the time we do endoscopy, we are going to see the lesions. We are going to be linear, shallow ulcers. And the person is going to have problems, swallowing. The person is going to have pain with swallowing or genophagia. Don't forget the description of the ulcer, linear, shallow ulcers, gives it away quick. CMV pneumonitis is just like all other atypical form of pneumonia, just like we have already said. They will have a fever, low-grade fever. They will have the cough, but the cough will never be productive. So they will have this sparse proton production because it is part of the atypical cause of pneumonia, right? So it may be associated with high mortality, it can kill them, just like PCP pneumonitis too. Both of them high mortality. So it is very common in people that have undergone transplant or people with hematologic malignancies than those with AIDS. So that's that about CMV pneumonitis. Don't forget somebody that has undergone transplant or somebody that's having AIDS. Although it might not be common in AIDS, but you still have it at the back of your mind. So hematologic malignancy, transplant patients now starting coming down with difficulty in breathing, dry cough. You might want to rule out CMV pneumonitis. Then the CNS involvement includes polyradiculopathy. They can cause, radiculopathy, referred pain to the legs, depending on the site. Then transverse myelitis, in which you just have like inflammation of a segment of the spinal cord, and the patient starts presenting with, lower upper motor neuron lesion distal to that part, you know, paraplegia, autonomic symptoms, difficulty in controlling bowel, movements, bladder control, a sensory loss beneath that level. Think about transmyelitis. It can cause subacute encephalitis too, in which the person just start having memory loss, irrational behavior, altered sensorium, personality changes. And for the congenital form, you see your periventricular calcification with microencephaly, sensorineural deafness, hepatosplenomegaly, but the periventricular calcification gives it away quickly. So there are different ways we can make diagnosis of an individual with CMV infection. We can do viral isolation culture, can culture the virus. We can do histopathology, which is the gold standard. We can even do a PCR analysis of the DNA, of the virus. So, but the best is histology, in which you are going to see, you know, this virus contained within the lymphocyte having intranuclear inclusions, which have the whole high appearance. We are very familiar with this. So once you see intranuclear inclusions having this whole high appearance, think about CMV. So how do you treat? You use your ganciclovir, your viral ganciclovir, your foscarnet. So beware of foscarnet in people with renal failure. You know, renal failure, foscarnet. Foscarnet can cause renal issues. So ganciclovir is part of this, usually first line, then you can use ganciclovir or foscarnet.